the last question. I can see we can pass to the next speaker, which is actually me. So I leave the chairmanship to Pasquale.
Yes, let me take the floor for a while to introduce our next speaker, who will be Ivan Fumagalli, who is a postdoc researcher in the iHEART group at Politecnico di Milano in the Department of Mathematics. So please, Ivan, I think you can already share your presentation.
Okay, I'm getting
and
there.
Ivan will talk us about patient-specific hemodynamics for the left ventricle based on images, an image-based computational pipeline.
Okay. Can you see the slide?
Yeah.
Okay.
Please go ahead.
Thank you. So thank you for the introduction, and thank you everyone for being here in this session. And this work has been developed in collaboration with other members of the iHEART group here at MOX in Politecnico di Milano, and also with a student from the University of Trento and some clinicians of Hospital Luigi Sacco in Milan and Hospital San Camillo Forlanini in Rome. The content of the presentation is this one. I will start with a brief motivation on the clinical reasons why we started this work. Then I will present the reconstruction procedure, the image-based reconstruction procedure that starts from diagnostical images to reconstruct the geometry of our domain of interest. Then I will describe the computational hemodynamics model that we set up on top of that, and show some numerical results that will allow us to give some clinical indications. Now, the motivation for this work is still in the set of hypertrophic cardiomyopathy, as that was described previously, described in the previous talk, indeed. But the idea here is the framework that we are interested in is the hemodynamical effects of this pathology. Hypertrophic cardiomyopathy is basically a thickening of the myocardium, and when the thickening interests, in particular, the basal portion of the septum, so near the aorta, we can be in the presence of an obstruction in the outflow tract of the ventricle, and thus we say there is an hypertrophic obstructive cardiomyopathy. This pathology is typically congenital, but of course also functional abnormalities can concur to the pathological framework. In a very severe case of this obstruction, we can also have the systolic anterior motion of the mitral valve. That means that the mitral valve, and in particular the anterior leaflet, is sucked towards the septum, so it's misplaced pathologically, and so it worsens even more the obstruction that we have at the outflow tract of the ventricle. This kind of situation can occur both in the case of abnormalities of the mitral valve, like for example, if there are some rupture of the chordae tendineae, but also it can happen in otherwise healthy mitral valves. So the goal that we set to ourselves is the numerical assessment of these pathologies and their effects on the hemodynamics inside the heart. And this aims at providing clinical indication, both to help diagnosis of the patient-specific situation, and also to help the surgical treatment in the sense of the design of the surgical procedure. Now, in order to do that, we developed a pipeline that starts from CNMRI, from diagnostical images, and reconstruct by that the domain of our blood pool and also the valves that are related to this left heart. In these geometrical settings, we set up a computational fluid dynamic situation in the moving domain, and this will allow us to derive some clinical indication, as I will show. So let's start from the first step of our pipeline, which is image processing. The data that we use is actually CNAM-array data, so it is a set of different acquisition series that have different features. The only series, at least in routinely acquired data in the standard diagnostical procedure, is the short axis series, which is three-dimensional indeed, and of course time-dependent. And although it has a good resolution in the transversal planes of the ventricle, it has a low resolution along the long axis of the ventricle. Other series that I acquired during the same diagnostical test are the long axis series that can be different, but they typically have only a two-dimensional slice represented, and therefore they do not provide information in the transversal direction. Because of this, the first step of our procedure is to produce an artificial image by upsampling and interpolation that can merge the information from the different series, and so to obtain an isotropic resolution of our data. I want to remark that in this way, we can also capture, of course, some of the details that in the short axis framework are blurred. Now, once we have this artificial image, we can move on to reconstruct our domain, and this is done by segmentation of the endocardium and of the epicardium at all time steps of the artificial image. Then these segmentations are used to make up a myocardium volume in a black and white image, and this is done by in-house developed VMTK-based tools. By simple elastics, then we perform registration on this myocardium in order to extract the contraction of the ventricle, and this contraction is then applied to the endocardium in order to have the boundary of our ventricle. The full geometry of the left heart, so the completion with the aorta and the left atrium, is done hinging upon a template geometry that in the present case is the one provided by Zygote. Now, if this represents the reconstruction of the blood pool, we also need to perform a meaningful simulation of the ventricle hemodynamics. We also need the presence of the valves. And in particular, here we can see how we use, once again, the template geometry of the mitral valve in order to make up to close physiologically the mitral valve on one hand, and also in the patient-specific case, so in the pathological case, to use the MRI data that we developed before to prescribe the motion, the displacement of the anterior mitral leaflet. In these geometrical settings, we set up our CFD analysis of the pathology at hand. And the mathematical model that is underlying the CFD analysis is based on the assumption that blood is in a compressible Newtonian fluid, so we use Navier-Stokes equations, incompressible Navier-Stokes equations. The domain motions is taken into account by means of the arbitrary Lagrangian-Eulerian approach, and the presence of the valve is accounted for by a resistive term, which is highlighted here in red. In particular, we use the resistive immersed implicit surface approach, in which the kinematic condition that the velocity of the fluid has to be equal to the velocity of the surface is imposed weakly by penalty by this term here. And this penalty term is activated by this smear delta function only in the neighborhood of the surface of the valve gamma. By this approach, by this implicit approach, we do not need mesh conformity with respect to the valve. And this is a good point to reduce the computational effort of the whole simulation. We have some similarities with the model that was described in the very first talk of this session, but in this case, the description by means of a smear delta is a little bit different than them. Now, these mathematical models get discretized in this way. We use piecewise linear finite elements for both velocity and pressure. So we stabilize them with an SUPG approach. And the RIS term takes into account the immerse valve. So our full numerical scheme requires the extension of the data here, DREG, reconstructed from registration, from the boundary of our domain to the full domain, to the full mesh, by means of a lifting operation. And then we are ready to update our moving domain and to solve Navier-Stokes equation in their stabilized formulation. On this scheme, we solve this scheme in the present setting. So we use the LifeX solver, which is developed in-house, and we consider in our simulation only the systolic phase. The boundary condition of our configuration are, since we're considering only systole, are a closed mitral valve and an outlet pressure at the outlet of the aorta that comes from Wigner's diagram. We're going to consider two patients, one with a non-obstructive hypertrophy and another one with an obstruction actually at the left ventricle outflow tract. So the two patients at hand have the following behavior. So we consider for both of them at the beginning a healthy closed mitral valve. This allows us to focus on the aspects of the hemodynamical effects of the displacement of the ventricle and only this. This displacement induces a jet flow through the aorta, which is way stronger in the case we have an obstruction. And this obstruction is represented indeed by the thickening of the septum that we can observe here. This thickening increases the peak velocity that we have in the aortic orifice, that gets high up to about 2 meters per second, which is in a pathological range. Whereas when no obstruction is there, we observe a physiological range of velocity. Associated to this velocity, there is also an interventricular pressure gradient, which is, of course, way stronger in the obstruction case. Now, in order to study even more in detail the patient-specific situation of this patient, we considered also the fact that we are in presence of a systolic anterior motion. So, as I said in the reconstruction part, we reconstructed also the motion of the mitral valve in accordance with MRI. And we noticed how the effect of SAM increases even more the peak velocity that we have in the aortic valve. And this reaches up to 6 meters per second. And this is, of course, associated with a high pressure gradient. To study and to give a better clinical indication for the treatment of this pathology, we actually saw how the pressure develops along the line which lays on the septum. And we could identify two zones, one in which the Venturi effect sucks in the mitral valve towards the outflow tract of the ventricle, and another region in which the interventricular pressure gradient due to the SAM actually develops. By identifying these regions, we can actually give indication to the surgeon, since the typical procedure that is used to treat this condition is septal myectomy, so the removal of a portion of the septum. So, concluding, the proposed computational line entails the processing of CMRI acquisitions in order to obtain numerical results and also to give the clinical indication that I just showed. The valves are taken into account by means of the resistive method RIS, which proves to be effective, at least in the hemodynamical sense. And we saw how both the hypertrophy and the motion of the valve concur in the creation of the obstruction of the ventricle. Some further perspective involved the investigation of other patients with different kind of hypertrophies, so with different geometry distribution of the hypertrophy, and the development of a reduced model for the valve in order to perform a reduced free structure interaction of the valve itself. Thank you for your attention, and this I leave some other references.
So thank you, Ivan, for your presentation. Is there any question? Please use your microphone or just write a message in the chat.
Okay.
So can I just drop in? I raised my hand, but
Oh, sorry, I didn't see it. Please go ahead.
In the beginning, you said you construct a 3D dynamic model by a series of short axis MRI, cine MRI.
Yeah.
And we experienced that the respiration gating is not always perfect, so that the slices do not fit together. They are tilted, shifted and tilted. And do you then use really the long axis, the one single long axis slice to, or could you just put them, the short axis slices on top of each other and you got a nice model?
No, indeed, this is a very good observation. Well, we were lucky, so some of the data that we had didn't have misalignment, so we were lucky and we could use the short axis as it was, but others actually had this misalignment, so some slices were of the short axis was misplaced, and we used indeed the long axis to in a pre-processing phase in order to recover the alignments.
That was a manual.
Yeah, at the moment, yes. This part, yes.
Thank you.
Okay, there is another question from Elias Carabelas. Okay.
Sorry, I had the microphone. I was reading the question.
The question is if we need any special numerical integration method to integrate the smear delta function. Actually not. Well, yes and no, let's say. Yes, in the sense that the smear delta needs to span across one or two elements on both sides of the valve, and this is the reason why we refined this region of the domain. But once we have this fineness of the mesh, we don't need any other specific numerical integration method. And another question from Mike Singer. The question is, does the high-speed jet in the pathological case induce turbulent flow, or does the flow remain laminar? And what's the typical Reynolds number for the pathological case? Well, the flow is quite never actually laminar in the aorta, at least during systole. And but still the Reynolds numbers are in the range of transition to turbulence. So for high velocities, actually we would need a turbulence model, but in this case this kind of approach was enough to capture the development of the flow. in a group, we are currently working also on this subject, and this will be a topic that will be covered by Alberto Zingaro on Wednesday in his presentation. Okay.
There's another question.
Okay, I think
the boundary conditions.
Yes. Which are the boundary conditions at the aortic outlet? Are they similar in healthy pathological conditions? So the boundary conditions are represented here. So we induce a pressure of the aorta, which is healthy. So it comes from Vigas diagram, and they are the same boundary condition is used in both the cases, because at the end of the day, what we are interested in is not the actual value of the pressure, but the pressure difference with respect between the aorta and the inside of the ventricle. And since in the systolic phase there is no inlet, we do not have a strong effect of the absolute values that we impose at the aortic outlet. Okay.
If there is no other question, we thank Ivan again.